Welcome to this video on the introduction to neonatal nursing. We will discuss the fetal to neonatal transitions and the physiological and environmental challenges newborns face. The objectives of this course include providing immediate care for neonates, performing comprehensive newborn assessment and history taking, performing physical examinations, assisting with neonatal resuscitation, and managing common neonatal problems. Let's start with some definitions. A neonate is a newborn infant, typically up to 28 days old. A neonatal intensive care unit, or NICU, is a specialized hospital unit for critically ill or premature neonates. NICUs are classified into levels. Level 1 provides routine care for healthy term newborns, or those with minor issues. Level 2, or special care nurseries, care for moderately ill or premature infants, offering continuous monitoring and advanced feeding support. Level 3 NICUs provide comprehensive care for critically ill newborns, including those with extremely low birth weight or complex medical conditions. They are equipped with ventilators and specialized surgical services, supported by a multidisciplinary team. The neonatal period involves the most dramatic physiologic changes in human life. The respiratory and cardiovascular systems change immediately at birth, while other organ systems adapt more slowly. The transitional period is a critical time for humans to adapt to life outside the womb. Physiologic adaptation is essential because the low-pressure placenta no longer manages gas exchange, circulation, and waste. Immediate changes at birth occur when clamping the umbilical cord and the first breath lead to increased arterial oxygen tension and decreased pulmonary vascular resistance. Pulmonary blood flow then increases left atrial pressure and reduces right atrial pressure. Adaptation is the functional adjustment from intrauterine to extrauterine life. Homeostasis is maintaining equilibrium in internal systems like blood pressure and temperature. Maladaptation can lead to morbidity. This image illustrates the differences between fetal and neonatal circulation. Note the presence of the umbilical cord, ductus arteriosus, ductus venosus, and foramen ovale in the fetal system. Two key factors influence neonatal adaptation: maturation, which is related to gestational age, and nutritional status, which is related to birth weight. Adaptation is a multi-organ process involving the cardiocirculatory system, respiratory system, intestinal tract, metabolism, and central nervous system. Cardiovascular system adaptation involves significant changes in vascular pressures after separation from the placenta. Specifically, pulmonary vascular resistance decreases while systemic vascular resistance increases. Neonatal cardiac output depends on heart rate, as non-compliant ventricles limit their ability to increase stroke volume. The neonatal heart is more fibrous and relies on ionized calcium for contractility. Neonates have dominant parasympathetic tone, causing bradycardia in response to stress. This contrasts with adults, who have a dominant sympathetic tone and respond to stress with tachycardia. Clinically, bradycardia can quickly lead to decreased blood pressure and cardiovascular collapse. Furthermore, neonates struggle to manage increased circulating volumes due to delayed diastolic relaxation and decreased filling. Exposure to oxygen and decreasing prostaglandin levels trigger the closure of the patent ductus arteriosus, or PDA. This closure allows more blood to circulate to the lungs and typically completes within 2 to 3 weeks of birth. If the PDA fails to close, a left-to-right shunt develops. PDA is an acyanotic congenital heart defect that can be surgically closed with ligation. The patent foramen ovale, or PFO, allows fetal blood to bypass the right ventricle and send oxygenated blood directly to the brain. It starts closing with increased left atrial pressure and may take up to 1 year to close completely. Respiratory system challenges include cartilaginous rib cages and decreased lung compliance. Neonates are susceptible to oxygen desaturation due to reduced functional residual capacity and higher oxygen consumption. Pulmonary adaptation involves the change from collapsed alveoli and high pulmonary resistance in the fetus to developed alveoli and decreased resistance in the newborn. Gas exchange shifts from the placenta to the lungs. In the hematologic system, neonates have high levels of fetal hemoglobin, which has a high oxygen affinity, resulting in lower arterial oxygen pressures than in adults. Vitamin K is administered at birth to prevent hemorrhagic disease caused by deficient clotting factors. The neonatal central nervous system lacks cerebral autoregulation, making the brain vulnerable to intraventricular hemorrhage during high blood pressure. An immature blood-brain barrier also increases sensitivity to lipid-soluble drugs. Regarding the endocrine system and thermoregulation, neonates cannot shiver or use vasoconstriction to prevent heat loss, relying instead on brown fat for non-shivering thermogenesis. Hypothermia is a stress response that increases oxygen demand and can lead to metabolic acidosis. In GI and hepatic adaptation, motility begins at birth, and nutrition transitions from placental supply to active intestinal absorption. Challenges include reflux due to decreased gastric emptying and lower esophageal tone, and the risk of necrotizing enterocolitis from hypertonic feeds. Nephrogenesis completes between 34 and 36 weeks. The neonatal kidney cannot concentrate urine well, leading to high initial output and a decrease in total body water. Low glomerular filtration rate makes neonates sensitive to fluid volumes and insensible fluid loss. In summary, transition involves rapid organ adaptations supported by cortisol and catecholamine. Lung adaptation requires fluid clearance and consistent breathing. Abnormalities in adaptation are more common in preterm births or cesarean deliveries. Thank you for watching this video on the Introduction to Neonatal Nursing.